Q&A, and I would say even more important than your questions, which we want to have, it's also your thoughts. What do you think about what we have been talking? What's your point of view of, these enablers that we've been detecting? So any comment or question would be very welcome before Steve concludes at the end with the wrap-up of your questions and views and our presentation.
In Spanish or English? Also in Spanish and English, okay? Because we know that some people prefer to ask in Spanish, so we can do it, okay?
My name is Jay Shaw. I'm a researcher from University of Toronto. Thank you so much for this overview. Really interesting to hear sort of 3 different cases of change and the many levels and kind of approaches required to make whole system transformation. So very interesting to hear about. My question is for Nuria. I'll hold my own comments. I'm still percolating, thinking. But my question is for Nuria. One of the things I'm most interested in about this is changes in governance or governance innovation required to support these collaborations. And you talked about this really interesting process in Catalonia, where there was a national group of experts and then a Catalonian group of experts, and decisions about which metrics would be used to govern collaborations between organizations were determined through discussion between these groups. Did I understand that right? Can you say a bit more about that? And then if you have other comments more generally about governance of collaborations, how did leaders at these organizations come together and establish these kind of formal agreements?
So I will also, if somebody wants to add any comment, and I'm not looking at anybody in particular who is an expert also from the region, he please feel free to jump in. So you just tackled a very important issue, I think, because every time we talk about these different types of collaborations, the rules of the game are very important. One of the things that, for example, I have not mentioned, because in the Catalan case didn't happen, is this idea of the money follows the patient. So in Catalonia, if the social services help the healthcare system, let's say, and together they could find a more efficient way, the money that you could save from healthcare was not sent back to the social services. Okay, this is something that it is still, if you ask me, work in progress. So now, what happens at the national level, the Spanish level? Really, the rules are very basic. There are just some general things that the healthcare system should provide. So the more important thing would be the outcomes. How do you measure healthcare? And at the national level, the directives are extremely general. So I would just say, look, this is what we want. You want some, not too many inequalities, healthy patients, but the rules are very, very general. Now, when you go to the Catalan system, that's where I think the governance is very important, and that's something, and that's my opinion, one should work more on. Because something that would make the difference is how do you measure these outcomes. And that's why I said that in the agreement, there's this evaluation process. You have to say, look, I commit to take care of my mental care patients in this particular way. And then you have to show that things not only not get worse, but they also get better. Okay? So basically, this is not what ended up exactly happening. What happened more was a governance of the process. So you as a region, you tell them how you would monitor these patients, what's the plan, who would be providing care when, and then if the process, if the commitment seems okay, that's what they accepted. So mostly was governance of the process, but I think it should have been more on outcomes, even though there was an evaluation of outcomes at the end. I don't know if there should be something else to add. But it's very, very important that the rules of the game are very clear. He's my Catalan expert in the room.
Okay, thank you, Nuria. You have explained it very well, better than us, I think. All the process and all the strategy we have with this kind of intervention plan, the identification of the patients, and which way we are working in this kind of 24/7 scheme. I think it's very interesting. The interesting thing in Catalonia in terms of governance is we have not put the focus on structural things, but also an instrumental approach, no? For example, to establish some kind of joint commissioning, to establish some kind of common goals between primary health care and hospital care. For example, avoidable hospital admissions, it is one of the indicators between primary health care and hospital care to achieve together. If you have the same indicator, if you have the same goal, maybe you are driving the different kind of providers to work together. In other terms, for example, we are fighting to have any kind of exchange of information, not only at the national health record, but also to establish some kind of connections between health and social care data. It takes a lot of time, it's a long journey, but we should fight to have this kind of exchange in terms of consent of the person and new regulations to facilitate this kind of thing. I think maybe in our case it's a combination of governance issues and instrumental things, and in the case of the government it's important to involve all the authorities who is responsible to take care of this population. So in our case we have the Department of Health, the Department of Welfare and the local governments, and it is very important to involve all the authorities in this kind of process. No? But I think it's a combination and a synergic combination of different kind of things to work in this direction.
Sorry, just to add to your comment. So it's not that every case that was proposed was accepted. So some people propose a path that was sent back to them and say, think about it twice, or again at least. Okay, but it's still, the rules are more on the process. So I think it's something that will take some time.
Yeah.
Thank you very much for this very nice presentation. I'm coming from Belgium, and in Belgium we are involved also in a project that looks at how to integrate care, starting from the issue of what we call local regional governance. But as you know, Belgium, as you may know, Belgium is much less structured as your systems in Spain. What I found very interesting is the four sort of key enablers that you presented in Catalonia that appear to be possible in systems that are not national health systems. So our systems is insurance-based systems with private providers, where primary care do not have any reasons to work with hospitals, and where primary care providers do not have any reason to work with social care. So all of these providers are independent providers. Maybe to Mr. Schortels, do you have experiences on how this type of key enablers can get implemented in countries that are not national health systems in such a way that they do not have, for instance, hospitals and primary care do not share the same budget, primary care and hospital do not share the same quality management procedures, they do not share the same care pathway, and so on.
Right. You want to start out?
I think that one thing, I mean, again, we are a national healthcare service, but for me, one key element would be maybe capitation. So if you pay for capitation for one patient, and then you say, okay, you do your best, this is how much I'm going to pay, and you decide yourself how you want to split it. That is one of the things. Catalonia is not doing that. We started with capitation and then we gave it up. I still don't know why. It's one of these things. But I think that capitation could be one reason, because basically if you have to find something that would bring the same incentive together. So you say, I'm paying you per patient and my outcome is healthy, or as healthy as possible population. And then if you trust them, let's say, with the right governance structures, you let them be. Because part of the beauty of this thing is that at the end, imagine how many resources it would require from a centralized government to decide locally what would be best. For me, that what makes a lot of sense with Catalonia is that they recognize that locally, if you trust your providers, trusting meaning I'm asking for these outcomes, that's what I want to monitor, and that's how much I'm going to pay for it, then you are the experts in this area. And of course, I will monitor. So if you don't deliver, I will ask for explanations and I will check. But then you organize yourself in the best possible way. And I think that's part of the beauty of, capitated would be maybe one of the ways, but Steve...
Yeah, just building on what Nuria has said, it's more challenging, no question about it, but capitation payment and going towards global budgets. So I'll just share a little bit of the experience in California as an example. And so in California, we have over time, influenced by Kaiser Permanente, but a lot of other developments as well, we have increasingly about 300 or so medical groups, and increasingly they are now under capitated kinds of payments. And we have some very interesting data from just maybe 6 months ago that show that patients in California who are getting their care from what we call still pretty much total fee-for-service versus what we call partial capitation, which is like for ambulatory and primary care, but not for hospital care, versus what we call full risk capitation, which is for the whole thing, inpatient hospital as well as primary care. As you go across, the quality of care based on about 15 different metrics, we can talk about if you're interested, goes up, and the cost per member, the total spending, total cost of care per patient per year goes down. It's some pretty powerful evidence. And so we're building on those kinds of models in California. We're not the only state. We're now working, we have a new governor, and the action in the states is at the state level more. In your countries, it'd be more of the provinces or the municipalities or whatever. And we're working with our new governor to try to expand that integrated care model so that when we go to universal coverage for people in California, we're going to be able, we hope, to sustain that over time because of the way in which we deliver care. So as Nuria has said, that creates a spending target up here. There's every incentive for those doctors and whatever hospitals they're working with to keep that population well. And oh, by the way, they can't stint on care or deny care because they have to first meet the quality metrics. Before they get any of the shared savings, they have to meet quality metrics as well. So this is some of the developments. I don't know how much would be, applicable in Belgium. You have to contextualize it, obviously, but there could be some learnings there.
Go ahead, I'm reading the app, sorry, go ahead.
Okay, perfect. My name is Yulia Sherbina, and I'm from Accreditation Canada and Health Assessment Europe. So thank you for sharing your experience with the integration of care. It's very relevant to other European countries as well. I'm thinking about Italy, for example, or other Southern European countries, for example. My first question is the digitalization of health records. So you have all shared your regional experiences, but how is that then implemented at the national level? Have you reached already the states where those systems already communicate between each other, and if you faced any challenges? And a second question is also related to, you have mentioned some rural communities, local communities. So have you been reinforcing and implementing the use of telemedicine in certain rural areas? And if so, what are the major challenges that you have encountered that so far?
Well, I will answer because, I also come from the health system. So, first of all, is that we have as you say, in our country we have a common portfolio of services, but the designing of the delivery services and the management is in the autonomous communities. This is one difference. So the decision of the kind of electronic health record is decided in each region, in each autonomous community. In some communities, there is a common electronic health record between hospitals and primary care. In another, there is a shared electronic health record. So primary care has their own electronic health record. Each hospital has their own electronic health record. There is a shared electronic health record. For example, this is the case of Catalonia or even the case of Madrid. And this shared electronic health record, it is really a platform of integration with a visor that allows to share all the relevant information. About the situation of connection of the different countries, of the different regions, of the different autonomous communities, Nowadays, there is a project, I am not from the Minister of Health, but there is a project to try to share key elements of the different autonomous communities, but it is a project. The only project that it is nowadays working, and it is common, it is the electronic prescription. So now there is an electronic prescription with all the active prescriptions of each patient that is shared, but all the pharmacists and all the systems in Spain. And for example, with a prescription that I give to one of my patients in Madrid, I can go to any place here and to have access to the medicine. This is the current situation. Okay? And about the telemedicine, just a view. Probably the situation of the telemedicine, well, telemedicine is a huge quantity of elements. It is not only to telemonitor. So now there are several experiments, I think so. For example, in this region, there were an example of telemedicine connecting different professionals. But I think it is not extended as a usual practice. It is particular in some places or wheres, okay?
Just to add in the first part of the question, I'm more simplistic than that. I understand that there are many problems with people sharing, but at the end, the data belongs to the patient. So once we understand this, I think that once we have the patient data folder, whatever name we give, that will be solved. I know that there are many silos, but for me, really, it should not be that complicated because the data does not belong to the Catalan government, nor does it belong to it belongs to the patient.
For example,
and
now,
if the patient can take the data with her.
Yes, in many regions, they have access to the electronic health record. Patients have access. So I can go to another part and give access to another professional. And this is an option too.
In telemedicine, if you are interested, there's one region in Spain that I think I could tell you about the Catalan.
Galicia.
So, of course, you incorporate telemedicine, especially for rural areas, but there's Galicia. Galicia, it's in the northwest. They have a very old, they have quite an old population living in small towns. I'm talking about towns that can have 20 people. So really small, okay? And their telemedicine has made a huge, huge difference, and there are many nice experiences that you might want to be